Hi, my name is Randall A, and I'm an infertility specialist in Orlando, Florida, and you found me on the Infertility Channel. Thanks so much for joining me. Today we're going to talk about one of the single most common endocrine disorders in the human. It's called Polycystic Ovarian Syndrome, or PCOS. PCOS is defined as having at least two of the three following. Number one, irregular menstrual periods. Number two, increases in androgen levels as demonstrated by oily skin or acne, increases in facial or body hair growth, deepening of the voice, temporal balding, and finally, a number of little follicles, little tiny egg-containing cysts around the inside lining of the ovary. At a meeting in Rotterdam in the Netherlands in 2003, it was decided by both the Europeans and the Americans to establish that as long as a woman has two of those three criteria, she in fact has PCOS. In patients who come to see us for PCOS, up to 75% will have infertility, and about 50% will have either a lack of regular periods or no periods whatsoever. Acne in 25 to 30%, and some increase in facial or body hair growth in 35 to 40%. Now it's interesting because studies have looked at the genetics of PCOS, and it seems to be so-called autosomal dominant, so that if a mother has PCOS, half of her daughters will as well. And this has been demonstrated in so-called concordant studies looking at monozygotic or identical twin girls. If one has it, the other is going to have it. But so-called fraternal twins, dizygotic twins, don't have that. So that, again, is a link showing some of the genetics. In terms of the diagnostics, we would look at a complete metabolic profile looking at kidney and liver function test. Also, we would recommend an oral glucose tolerance test. Glucose is the blood sugar. So we ask the patient to drink a sugary, cola-like drink, and then we get blood tests on the order of every hour for 2 or 3 hours. And that will tell us how she is metabolizing or processing her blood sugar. We know that one of the key components in many patients with PCOS is insulin resistance. Insulin resistance means that the pancreas is working really hard to try to get blood sugar into the cells of the body, especially the peripheral muscle cells. But it is hard for that sugar to get in there. So the pancreas continues to produce more and more insulin. Now, insulin at the ovarian level has different actions, but especially it seems to increase the androgens like testosterone. So insulin resistance is a component of many patients with PCOS. In addition, there is increased amount of an enzyme called aromatase. Aromatase is increased in the fat cells. So as patients have more in the way of body fat, they convert more androgens, like testosterone, into estrogens. And so that produces a curious state in the same person of having too many estrogens and too many androgens. And that causes them to be stuck, so to speak, in the mid-cycle. By that I mean that their luteinizing hormone to follicle stimulating hormone ratio is usually 2.5 or 3 or greater to 1. That favors, again, too many androgens, too many estrogens, and that's just a vicious cycle. And so without some medication, without some way of breaking that cycle, one is not likely to ovulate. So after we've ruled out other diseases that can look a whole lot like PCOS, such as congenital adrenal hyperplasia, that's where the adrenal glands are not formed normally and produce too much in the way of androgen, or Cushing syndrome, where there's too much serum cortisol, or even too much prolactin from the pituitary, all of those can look a lot like PCOS. So we're going to rule those diseases out and then start treating PCOS. One of the things we're going to do is ask patients to observe a high protein, low carbohydrate diet and have daily aerobic exercise. If they do that, they can modulate or reduce the excursions in their insulin levels and therefore have decreased insulin drive at the ovary. Sometimes we use nothing more than insulin sensitizing agents such as metformin. Other times we use medicines like Clomid or letrozole, which induce ovulation. They help the woman to produce an egg or two in a cycle. So we have to find some good way to break that. I know all this sounds kind of crazy, but just suffice it to say, if we can lower the insulin levels, we have a good chance of succeeding in ovulation. And that's the deal. We have to help these patients ovulate. And we can do that through oral medications, through injectable medications, or even in vitro fertilization. We have to be very, very mindful, however, in this subset of patients because they are at risk for ovarian hyperstimulation syndrome. And recall that ovarian hyperstimulation syndrome means that the ovaries get enlarged, tender, multicystic, increased risk for nausea, vomiting, problems with the kidneys perhaps, and even blood clot formation. So we're very, very mindful of that risk in this particular subset of patients. So much of PCOS relates to diet and exercise. I had a very young couple recently. They were in their mid-20s, and she was obese. Her husband kind of scared me. He had a dark hoodie on, his neck was completely tattooed, all of his hands were tattooed, and he had dark sunglasses on. And for the first 30 minutes of the consultation, he didn't say a word. In fact, when he came into the room, he didn't even shake my hand. He just sat down. And about 35 minutes in the consultation, he reaches into his hoodie, and I thought he was gonna pull out a gun, and he pulls out a big can of Pringles, and he starts crunching them loudly. He ate them quickly, and then he says, "Where's the nearest Burger King?" I said, "Excuse me?" He said, "I'm hungry for Burger King. Where's the nearest Burger King?" And I said, "I really couldn't tell you. I don't know." He says, "Come on, baby, we're going to Burger King." And she says, "Well, can we finish with the doctor?" He goes, "No, I want Burger King." So they left, and I never saw the Burger King twins again. I hope she became pregnant, or at least I hope that she's eating better. Thanks so much for joining us again today on the Infertility Channel. Love to see you back next week. If you've not subscribed, please do so. Tell your friends about us. And if you have any comments, please leave them. And if they're of a personal nature, write me at the email address below, and I will incorporate your questions, concerns, comments in a future episode. Thanks so much.